Welcome to the Healing Guardian. We're going to discuss sociology and anthropology, grasping the ABCs of mental health. Medical sociology and anthropology are going to be applying anthropological studies in medical practice and how anthropology and sociology is important for future doctors. The scope of the video, we're going to look at definitions and theoretical orientations in anthropology, the health and illness in cultural context, African or indigenous knowledge and ethnomedicine, medical pluralism and healers collaboration, health risk behaviors and lifestyles, marriage, family, work, social relations, doctor-patient relationships, HIV or AIDS and the pandemics. Epidemics talking of Ebola and cholera in the view of sociology and anthropology. Section 1, we are going to have 7 sections. The work has been divided into 7 sections. The first section, we are going to look at introduction to sociology and anthropology. Understanding people and health. Sociology and anthropology reveal how society, culture, and human behavior fundamentally influence health. We are going to be looking at how the society, their culture, and human behavior influence health. These move beyond just biology, but to explain why people get sick and how they seek healing. For example, considering rural communities where traditional herbalists are often the first choice of illnesses, we reflect deep trust it reflects deep trust in local systems and cultural beliefs about disease causation, even for conditions a hospital could treat. Many times the society, the culture, and what they believe influences much about their health, and that is what you are going to be looking at in sociology and anthropology. What is sociology? Sociology is the systematic study of society, social groups, and human behaviors within those structures. In sociology, we examine how institutions like family, religion, and shared norms they shape individuals' lives. If we are looking at, for example, in Uganda clan system, the study of sociology will help you to understand the social organization among the Waganda, their taboos, like the strong prohibition against marriage within the same clan, and these demonstrate how social rules dictate individual choices. Many times what we do is dictated by the society we live in, and what we do will eventually is the basis of our health status. So in sociology, we are looking at society and human behavior, how they affect people's lives. But anthropology generally is a holistic study of humanity and culture in its natural context. Anthropology is more broad and it is fixed at the natural context. We are looking at cultures, meaning you study people's culture or you study humanity in its natural context. It aims to understand people from their own internal perspectives, what we call the emic view. For example, if we are looking at actually cultural practices, they reveal how beliefs like maybe blood compensation are linked to perceived illnesses and well-being, and how they influence their health-seeking behaviors alongside or instead of modern medicine. So sociology and anthropology, however much we are all looking at people's behavior, but sociology we look at any society or social group. We study its behavior. Then if we are looking at medical sociology, how does people's behavior affect their health? In anthropology, it is more of studying humanity and culture itself and how in its natural context, then we apply this data in medical practice, how it can improve medical practice. So there are basically two lenses that we use in sociology and anthropology. Sociology studies human societies and how individual behavior is shaped by groups and institutions. For example, we talk of family, religion, and the economy. Many times in sociology, we start at the Western viewpoint, but in anthropology, we are studying human beings and their cultures in their own contexts. That is why many times in anthropology, you look at how people view their cultures, meaning in their own context, you get their perspective, and you use these various perspectives to understand how they view the world. So sociology and anthropology are different. Sociology is generally studying societies and individual behavior. It may go to how what people do, what they do on a regular basis, even if I'm focusing on an individual person. But in anthropology, I look at a culture or human beings in context. So that the views are much wider. Anthropology in medicine and anthropology of medicine. Anthropology in medicine acts like a bridge between the clinic and the community. Anthropology in medicine is the practical use of anthropological data to help doctors improve medical services. And this is what we are going to be focusing on in anthropology in medicine. How do we apply data from anthropology to improve medical services? But anthropology of medicine is academic study of medicine itself as a culture system. Anthropology is wide. You may say anthropology of sports, anthropology of culture. That in anthropology of medicine, you study culture as medicine. But anthropology in medicine, which we are going to be looking at in medical anthropology, we are using anthropological data to help doctors to, to improve medical services. In patient care, you can explain the Angel's model as a three-legged stool of patient care. In this model, it is also called the holistic approach in treatment, which is also called the biopsychosocial model. The bio deals with the physical body. When you are dealing with this in medical practice, you'll use medicines and surgery. But the psycho deals with the mind. You talk of emotions. When you're dealing with the psycho part of patient care, we talk of counseling, giving antidepressants. Then the social part, we are looking at culture, family, and beliefs. Then the religion and employment. Therefore, in Angel's model, he suggests that while dealing with patients, it is well-being is holistic, not only focusing on the bio, but also on the psycho and the social. For example, in the bio, the doctor may run tests, prescribe medication. Then in the psycho, as a doctor, you may address the stress, anxiety, the feelings of failure that the patient has. Then in the social, you'll need to understand the intense family pressure for children, like in when you talk of a patient coming with infertility. You also look at their social part. They might be having pressure, social pressure. They might be facing social stigma, which can also lead to marital problems. So patient care, according to Angel, is a biopsycho social model. This is just the foundation for anthropology in medicine. Then culture is broad. Many times what we see as culture is just the tip of the iceberg. A small part of culture is visible, like how people behave, their food, their dress, their music. This we can see. But the largest, most powerful part of people's cultures, like beliefs, values, their styles of communication, their concepts of self, their attitudes towards authority, these are things which cannot be seen and can only be studied, or which we can only get through anthropological data. So many times culture, we just look at the tip of the iceberg. In Uganda, a patient might might look you in the eye, maybe has come for consultation, and you might see it as if they are dishonest or they are not sure of what they are talking about. But there might be an underlying cultural value which you cannot see. Probably they are not looking in your eyes because they are showing deep respect for you as an authority or as a doctor. So many times, culture, when you're studying culture and applying culture in treatment, in disease prevention, we understand that culture is a broad concept. It includes people's beliefs, their values, their styles of communication, and also their attitudes. So it is not all about their dances, how they dress, but it is broad. When we are studying culture, there are branches of anthropology. Remember, we said anthropology is the study of human beings and culture in their natural contexts. There are some people who study cultural anthropology, where you study human culture and society. They go in various areas, we study people's cultures. The linguistic anthropologist will study language in its social context, but they also study human beings using archaeology. They study the past cultures through material remains. So you establish people's cultures by using archaeology. You can also study people's cultures and human beings using biological anthropology, using concepts of human evolution and adaptation. And in all these branches of anthropology, they employ different theoretical perspectives as we will talk about them. So in the biological anthropology, someone will employ perspectives like the ecological, the evolutionist while studying people. Then applied anthropology, which we are going to apply, which we are going to use, because in anthropology and medicine, we are applying anthropological data, whether from cultural, whether from biological, whether from archaeological, we are applying it in a specific field to solve practical problems. So there are mainly four types of branches of anthropology: cultural, linguistic, archaeological, and the physical. But all these can be applied in various contexts to solve practical problems. That is when it is called applied anthropology. Why does anthropology matter in medicine? By the end of this video, you'll realize it in its full context, that most of the things we deal with in public health interventions, in doctor-patient consultation, in treatment, they depend on people's culture. For effective health care, doctors must understand that patients' culture, beliefs, background, and social contexts, they what? They affect their adherence. They can lead to miscommunication and poor outcomes. The better you understand the patient, the better the treatment. A culturally sensitive doctor, if you are in a Muslim country, you will accommodate a Muslim patient's prayer schedule if they want to have their prayers during treatment in a hospital. There you are being culturally sensitive, and this builds trust from the patients and ensures holistic care. So when you're dealing with medicine, it is not all about the biological part, but culture, people's beliefs and values matter a lot in medicine. Cultural benefits. In medical anthropology, which we call the study of medical phenomena as culture, for example, studying illness and healthcare as culture, it applies cross-cultural knowledge to improve healthcare, sanitation, disease control in different cultural contexts. For example, when we talk of when we talk of making interventions, if you are going to provide treatment, okay, if you are going to provide, you are going to prevent a certain outbreak in a certain area, it is important to understand what the views of the people in that area about what you are preventing. their beliefs on the causes of the illness, their beliefs on how it has to be treated, their beliefs on the signs and symptoms, because it will affect how they embrace that intervention. So many times it is important to study medical phenomena, whether it is illness or healthcare, as a culture. And when we apply this cross-cultural knowledge, it helps us in disease control, in healthcare, and in improving sanitation. When you're doing medical anthropology, there are mainly two approaches: the emic approach, which is also called the insider, and the ethic approach, which is the outsider view. In the emic approach, we understand how people view their own situation. You know that people view their situations in different ways. You understand how people view their own situations, and you use it to study their culture or their behavior, or you use it to treat them, you use it to know which interventions to use. But in the ethic approach, it is based on the ideas of the outsiders, what others think about it. For example, the policymakers, the health workers, and this is called the outsider perspective. So if it might be a certain illness, in the emic approach, the patients or the people, they have their own view about that illness. A mother may have a child who has a folk illness which they believe is caused by spirits. Then also a doctor has his approach or his point of view, and is looking at maybe these convulsions, you having a baby having convulsions, and you're relating it to cerebral malaria. So many times the emic and ethic approach may not be the same, or they may conflict, and they affect how healthcare is given and how patients adhere to the treatment. But besides that, also the emic and ethic approaches are used in study of people in anthropology. Sometimes if you want to understand how people view certain things, their beliefs, or prevalence of certain illnesses in certain areas, it is best if you approach the people themselves and interview them. But there is also a study of anthropology where we are looking ethic approaches. You look at the political economy, how it is affecting the people. If you look at the ecology, in the ecological approach, mainly we are using emic ethic approaches. That in emic approaches, you may use them in anthropology of experience. You go, you interview the people, they tell you their view about their own selves, their own selves. Those are the two approaches. And in the last part of this introduction, we need to understand the theoretical perspectives we use when you're studying anthropology. We have the ecological, the evolutionist, the cognitive and symbolic, the anthropology of experience, talk of critical medical anthropology, the political economy, and the transactionalist perspective. These are the different ways anthropologists analyze health issues. Different anthropologists, medical anthropologists, will use different views according to circumstances, according to their own knowledge or their preferences. There are many factors they depend on. So many times the problem may be the same. If you look in this illustration, reality can be so complex that equally valid observations from different perspectives can appear to be contradictory. These two are looking at the same thing, but according to their perspectives, are making different conclusions. So even doctors apply different perspectives. So if you are learning about different diseases in Uganda, these theories will help you move beyond just the biological cause, because we use them in anthropology to see other factors, the social, the environmental, the biological, the ecological factors that influence health and disease. When we start with the ecological perspective, and this is applied in many ways. In ecological perspective, health and disease are viewed as outcomes of interaction between humans and their environment, whether physical, biological, or social environments. So in the ecological perspective, the anthropologists will focus on environmental conditions. You look at climate, you look at water, the housing, the nutrition, the pollution, and you analyze how these environmental conditions they are shaping patterns of health and disease. So you are using how the people's environment affects disease patterns. So in public health interventions, many of them, like vector control or improving sanitation, promoting proper waste disposal, they come from this perspective because we believe it is the environment that is responsible for health and disease patterns. And we have this example in ecological. If you are looking at obesity, maybe having prevalence of obesity in a certain area. The rise of obesity when a population moves from a farming lifestyle to a sedentary urban one. In this case, we explain in ecological perspective that what is causing the increased rise of obesity, it is actually moving from a farming lifestyle which was more active to a sedentary urban lifestyle. So that is an ecological perspective. It is the environment that is responsible for the disease or the disease pattern. So it is the shift from active farming to a more sedentary office jobs that is which we are calling an ecological change, which is leading to the rise in non-communicable diseases. But even if you don't look at that, you can look at malaria in ecological perspective. You understand that it is the stagnant water or the flooding, which is or the what? The tall grasses that is causing the increased breeding of mosquitoes. That's why there is high prevalence of malaria in sub-Saharan Africa. There we are studying in ecological perspective. But we have evolutionist perspective. In the evolutionist perspective, we examine how medical knowledge, understanding of disease and health systems are evolving over time. So in this case, the medical anthropologist will be analyzing how does the change how has medical knowledge how has it gone go how has it gone evolving. So if you are comparing two areas, you are comparing Europe and Africa, you're saying how does difference or maybe the difference in evolutionary trend affecting the health system. So you'll come to Africa, you look at maybe the rudimentary medical system, the rudimentary methods. Then you look at Europe having better methods which are better modified, or even understanding of disease. That in evolutionist perspective, you may look in Africa, they believe disease is being caused by spirits, by what? Then you go to Europe, maybe for them they are more of looking at scientific rationality, they test, they believe it is caused by germs. So in this perspective, we explain disease and health patterns using how medical knowledge, understanding of disease and health systems have evolved. So in this evolutionist perspective, understanding historical evolution of medical practices helps to integrate traditional medicine with modern care and to improve acceptance. For example, modern herbal medicine research can build on traditional knowledge rather than dismissing it. Because in evolutionist perspective, we believe this traditional healing and spiritual healers was just the first form of it. So they can work together or they can be used interchangeably. That is the perspective of an evolutionist. Cognitive and symbolic perspective. In this case, it focuses on how people think about and symbolize illnesses. And in cognitive and symbolic perspective, a lot of times you go to the people, you interview them, you look at their culture, beliefs, and values. Then you look at how do they symbolize illness. How do culture symbols and beliefs give meaning to suffering? For example, in some Ugandan cultures, There are persistent nightmares or strange behaviors that are understood to be symbols of spirit possession. And they dictate that to heal from that condition, you have to go to a spiritual healer rather than by a medical diagnosis. So if you are a medical doctor, you can apply anthropological data to understand how to make interventions or why people are not taking on the intervention. Many times in a cognitive and symbolic perspective, the people in that culture have the way they view illness in a symbolic way. So the implication, doctors must understand the meanings that patients attach to illness and healing in order to communicate effectively and provide holistic care. A patient may view HIV not just as a virus but as a curse. Therefore, care must address both the medical and the perceived spiritual dimensions, because if you don't tackle the perception, it affects their adherence. Here there is an example in Acholi culture. They have the term Chen, which refers to a vengeful spirit. And in Acholi, this is a symbolic way of understanding and explaining persistent misfortune, including chronic illness that has no clear biomedical cause. Therefore, to them, this evil spirit gives meaning to their suffering and dictates that the solution is a spiritual solution. But even if it is not in actual culture, in many cultures, there are some conditions where the public generally agrees that that condition, there must be a problem. Or a child has asthma, suffering from asthma, then you say that that child needs to go back to their ancestral land, and this, such stuff, that is symbolic. So in cognitive and symbolic perspective, as a medical anthropologist, you look at a culture, you find out how do they view illness and how which causes or which symptoms or treatments do they attach to it. The political economy perspective. This is also a common perspective used by many medical anthropologists. This perspective connects health to large-scale political and economic forces like global capitalism and national policies. So in this perspective, they ask who gets sick and why and who profits. Because many times the problems or the cause of illness or that why that disease is prevalent in that area is due to forces which are greater than the people themselves. You talk of political inequalities, poverty, you talk of social inequalities or unfair systems. So in this perspective, the anthropologist, you explain the prevalence of health-related events due to political, economical reasons. So this implies that medical care must address inequalities caused by economic and political systems that limit access to health services, drugs, and infrastructure. If you consider how national policies on land use in Uganda, or if you talk of the global trade agreements, they can impact food insecurity. They can impact nutrition in rural Ugandan communities, thereby affecting people's health. So you address the the policies, or the inefficiencies in the government, talking of corruption affecting supply of medical needs. If you talk of unavailability of health services, those are political economic reasons. An example is the tobacco industry, explaining political economy perspective, analyzing how tobacco companies market cigarettes more aggressively in low-income countries. You can observe how large tobacco companies they target youth in Uganda with cheap single-stick cigarettes despite the health warnings, prioritizing over their public health. So in this case of this example of the tobacco industry is that you're having that due to economic inequalities or due to economic gains, you find like this case the tobacco industry aggressively advertising something that they perceive to be harmful but enforcing it on the public. So this is a political economic inequality. So they have prioritized their profit, how they benefit over the health of the people. So an anthropologist studying in this perspective will also look at such factors and how it is affecting the people's health. Critical medical anthropology. For this perspective, it is a combination of the political economy and symbolic perspectives. So you aim to study, you are so critical to understand the causes, factors, so that you get good solutions. It critiques power imbalances and examines how social inequality shapes the experience of being sick. For example, when you are studying HIV in Uganda, a critical medical anthropologist would not only look at the economic inequalities, but will also look at the stigma and cultural beliefs that impact testing and treatment outcomes, because there is that perception that people have. So if you are looking at prevalence of HIV, critical medical anthropologists will first look at the power structures, the poverty, the inequality, people not having access. But we also look at the symbolic. How do people view HIV? How do they look at its treatment? What are their perceived ideas? Anthropology of experience. In this, you focus on the lived day-to-day personal experiences of illness of the patient. You interview the cases. How does it feel to live with this condition? You listen to the patient's story. So you understand the daily struggles of the patient. Maybe if you're having someone with drug resistant tuberculosis, you interview them. How do they feel it? How do they tackle it? So you are studying behavior, you are studying culture, using those, or you are studying medical phenomena by interviewing the people who are affected. So it might be due to social isolation. If you are looking at cases, people having a certain illness, or you are looking at HIV patients, you go and you interview them, they tell you their life, whether they are being isolated, difficult accessing food. So if you are analyzing such stuff, you need such a perspective, the anthropology of experience. You need to use the emic approach. A given example is the nodding syndrome in northern Uganda. For this case, you can combine two perspectives. You can combine the political economy and the anthropology of experience. You can go to northern Uganda and you assess how does the post-war political, political and economic neglect of the region created conditions for the disease. Because chances are high it is because of the war that was in northern Uganda. Then after assessing those factors and inequalities, then you look at the experience. You go to those people who have been affected, people with nodding syndrome. You interview the families so that you document and the profound daily suffering, the social stigma of living with this nodding syndrome. So in this case, the medical anthropologist is combining two perspectives in order to get enough conclusions. And the last perspective is the transactionalist perspective. And this is about negotiating in health. Many times, this perspective views health interactions as a series of negotiations or transactions between individuals, groups, and institutions. It focuses on how people bargain or compromise and exchange resources in pursuit of their health. So in the transactionalist perspective, many times people make negotiations in health. If a patient goes to a certain private clinic, They may negotiate on their treatment. Many times people will assess the cost. Many times people will assess how do I benefit. You have made a public health intervention. You have provided screening tests. Maybe you are using HIV screening or cervical cancer screening. Many times people look at health, okay, they negotiate with their health. There are those who will first consider the cost. Is it cost effective? Then there are those who will consider the value. How much do I benefit? Number two, many times in clinical settings, patients, there is exchange between the patient and doctors. The patient will put their trust in the doctor and they expect to be exchanged with quality service, with treatment, all that. So many times the factors that affect people's health, they are addressed in a transactionalist perspective. If you are looking at HIV prevalence in Western Uganda in a transactionalist perspective, you look at how people's daily transactions they affect their health. Many times people put their health at stake because of personal gain. If you talk of transactional sex or increased prostitution, someone is doing it for personal gain but at the expense of their health. So there is negotiation in health. That is, in a transactional perspective, you are assessing those negotiations or transactions that take place day to day, either between doctor and patient or in their day-to-day life, the transactions they make and how they affect their life. So a patient may trade their labor or produce for a healer's services. They go, they harvest food, what, then they come, they give you the food, you give them the what? The medication. Or they can negotiate payment plans with private clinics. But also biomedical providers might negotiate the patient compliance in exchange for perceived cures. Many times you have to convince if you take this drug, this is how you'll benefit. This is there are those negotiations that take place in health or which affect people's health. So it is either between the doctor and patient or it is in the people's lives themselves, transactions they make for personal benefit which affect their health. So it is a broad perspective and it has a lot of implications. In transactionalist perspective, traditional medical care involves exchanges. For example, we have talked of patients, they give their trust, their money and compliance, while the doctors will provide knowledge, treatment and healing. So as doctors, you have to ensure mutual benefit and trust by offering quality care, respect and clear communication. Because many times people's adherence to treatment or their willingness to approach clinics, it is many times due to betrayed trust because they are looking at it as in a transactional way. If we talk of health seeking behaviors, many times the patients will evaluate the health system, whether it is a traditional healer, hospital or pharmacy, and they see which one gives them the best perceived outcome. People will look at how cheap is it, how fast does it cure, how is it acceptable in our culture. So meaning if you have a health facility, you have to improve patient satisfaction. Many times people in different cultures they find it easier maybe to approach the traditional healers to use herbal medicine because it is cheap. That is a transactionalist perspective. They may go to the traditional healer because they feel it is it is more acceptable in their culture, or because of patient satisfaction. If patients go to hospitals and they are handled poorly, they don't feel that satisfaction, they will choose a system where they are valued. That is transactional perspective. If you talk of community health programs, the success of these programs depends on whether people feel they gain something or not. So if you're making public health campaigns, ensure that you offer visible benefits. For example, if you make a public health campaign and you're giving people free mosquito nets, Many people will come because they are because of that transactional perspective. But even when we look at the doctors themselves, the doctors they also need motivation because health workers view their service as a transaction. So since if I'm giving a delivery, I expect to be paid enough. So if the doctors or the medical professionals are not cared for, in the transactionalist perspective, we look at how health is affected by these transactional views. Many times health services are very poor because the medical professionals are not being cared for. So policies must ensure fair incentives. If we talk of health insurance and cost of care, the government should subsidize the structure health insurance because many times people fail to access services because they don't have the money. An example in Uganda, a mother may choose a traditional birth attendant over a hospital because there she's receiving more care, more respect during childbirth, even if it is more riskier. They find many people are informed, they know that midwives are there, but they find they are more comfortable with traditional birth attendants because, first of all, that is their culture. Number two, they are cheaper, maybe they are more caring, they treat them well. So that is a transactional. People look at health as a transaction. So that marks the end of our introduction, and it was the longest because it makes the foundation of all the rest of the things we are going to talk about. So we have looked at the theoretical perspectives that when you are studying people's culture, when you are studying medical phenomena, there are many perspectives you can use. You can look at the systems, you can look at the politics, the economy. You may interview people to get their views. You may look at people's perceptions towards the illness. What do they think is the cause? Because it all matters in how you treat them. Section 2, how does culture, social relations? We're going to look at culture, social relations, and health. How culture shapes, how culture shapes our world, how culture affects people. So starting with the social relations. When we talk of social relations, we are talking of interactions, connections, and bonds between individuals and groups within a society. So these encompass a full spectrum of human interaction, talking of deep love, kindness to hostility, conflict, and isolations. In social relations, we are looking at how people are interacting, or the bonds between them. These social relations depend on attributes of people. For example, good social relations, positive social relations will be fostered by attributes like kindness, empathy, being loving, being honest. They promote good social relations. Remember, we are studying society and how it affects the health. And we are going to see that when you have positive social relations, they affect our health, even negative social relations. So this is the fabric of well-being. Positive social relations like kindness, love, empathy, strong community ties, they foster positive social relations. These attributes lead to positive social relations, which significantly enhance mental and physical health. You talk of in the culture systems, when you talk of those activities that people do together that unite them, these positive social relations are good for people's health because they provide social support, they reduce stress, they build resilience, and can even influence people's health seeking behaviors. In Uganda, they had the Bulungi Wansi. So when people have good positive social relations, their health is generally improved, whether in an extended family, when they are working together, sharing responsibilities, sharing joys, sharing burdens. And for these social relations to be there must be good attributes which which foster relationships. We talked of kindness, love, respect, name them. But the negative social relations, many times they lead to poor health. If you talk of hostile interactions, discrimination, social exclusion, they generate negative social relations that severely damage people's health. You talk of the many times people in their old ages, many old aged people may feel isolated or they are abandoned, and it is significantly affects their health. They increase stress, they lead to chronic physiological responses and can contribute to mental health issues. So sociology is an important part of health because we not only focus on you waiting for a person to get sick and you handle the mental disorder, but how people relate, how people deal with each other, the social networks they are in, they affect mainly their mental health. What is culture? Culture is a shared learned blueprint for living within a group. It is like a blueprint of how you are supposed to live irrespective of your culture. It contains the collective behaviors, the beliefs, the values, and rules. If you go to the Banyankole and there is a culture that whenever you visit any family, they have to give you milk or they give you is it omushozi? So for them they will associate it that when you give milk to visitors, it is a gesture of respect, hospitality, sharing prosperity. So it is a learned social norm. Culture is learned and gives a blueprint that the Baganda behave this way, the Banyankole, the Acholi. So we define culture as collective behaviors, beliefs, values, and rules that define how people should live within a certain group. But important in medical anthropology, as we stated earlier, that culture shapes our health. Culture profoundly defines what people believe that causes illnesses. We talked of convulsions. There are many societies where they see a baby with convulsions and they believe it is an evil spirit, even if it might be cerebral malaria or meningitis. How people interpret symptoms is also defined by their culture and the treatments they prefer. This will influence their health practices, their diet, and their hygiene. In central Uganda, there is an example of a vino, or what they call the false teeth. It might also be in other cultures. So they believe that whenever childhood diarrhea is caused by these false teeth. So it can lead to dangerous tooth extractions rather than taking the baby to hospital, maybe to extract that tooth. So in this case, the people's culture is that it determines what they perceive as the cause of illness. That is what brings out the importance of cognitive and symbolic perspective. How do people view their condition and how they interpret symptoms? That you look at someone with convulsions, that is an evil spirit. When you talk of preferred treatment paths, that when you have this, do this. When you have such a situation, this is how you have to treat it. It is all determined by people's culture. Meaning study of culture is very important. Culture is everywhere. It will permeate all aspects of life. Talk of people's beliefs. Talk of morals, what they believe to be right or wrong. It is determined by their culture, their laws, and their daily habits. So culture provides a framework for understanding and interacting with the world. Whether you talk of the Kwanjula ceremony among the Baganda, where people have to showcase their specific attire, their cultural dresses, their rituals. It is everywhere. Culture and health beliefs. As we said earlier, culture offers diverse explanations for illnesses, often differing from biomedical views. So if you only wait for a patient to come to hospital and you give them tablets without looking at their perceptions and their culture, there is no adherence and generally health is low. These causes may be supernatural, like you talked of the chain among the Acholi, or social imbalances or due to environmental factors. So culture cannot be ignored. We have talked of the convulsions and how people believe they are due to evil spirits. Illness versus disease. These are two perspectives, one for the doctor and one for the patient. Disease is the objective biomedical pathology because a doctor will believe it is caused by a virus, it is caused by bacteria, and it is identified by doctors. So it is objective. It doesn't depend on anyone. But illness is a subjective, personal, cultural experience of being unwell. How someone perceives it according to their culture and how they perceive it that now I am unwell. And this brings in issues because many times people can be screened for a disease when they don't believe they are ill. And that affects adherence. If you screen me and say I have a disease but I don't feel that I am ill, I will not take the drugs. But also there is illness without disease. A patient comes with illness, says I'm sick, I feel this, then you check everything, there is nothing. So it affects the doctor and patient relationship. So illness is more of the perspective of the patient, disease is the perspective of the doctor. You diagnose a patient with measles, but when the mother of the baby, he believes that the baby is having these skin rashes, maybe they are because they have eaten very many mangoes. So there are different perspectives. Sickness is the social view, how the society views it. Because to the society, sickness encompasses the social implications and the roles associated with being unwell. If someone behaves like this, then they are sick. It is the society that dictates. It dictates who is considered to be sick. It dictates their obligations and how they are treated. And the society is the one that determines. So the study of society, it makes it very important. In this society view, you can look at the perspective of HIV. In many societies, there is that social stigma that the society attributes to the disease. And this can cause a lot of problems to the patients that are suffering from HIV. It leads to social isolation, discrimination, even if there are medical advancements. So even if a patient is being treated and they are being isolated, chances are high their health will not improve. Looking at the concept of social view, there is what they call medicalization in different societies. Medicalization is the process of defining normal human experiences and social problems as medical conditions. Normal human experiences can be medicalized by the society and can sometimes pathologize everyday life and shift focus from social solutions. You are looking at this example, two mothers having two children fighting. Then one mother says it is not his fault, he's just a little aggressive. He has got seriously medicalized behavior disorder. So that is just a nickname. That they have just seriously medicalized the disorder. That child may be just stubborn. So in different societies, they have a tendency of medicalizing because there is a way they view sickness. So you can look at someone who is normal, but in a certain society is considered to be sick. That is medicalization. Section 3, African medical knowledge. We have seen how culture shapes people's lives, but also culture affects the medical system. Because from culture to culture, they have different medical systems, meaning even the methods they use to treat are dictated by their culture. Culture is part of health. The African medical systems are generally pluralistic. This means that people often use multiple health seeking pathways. If you talk of the professional sector, the popular sector, the folk sector, villagers Maybe if you talk of villagers in central Uganda, they may often use herbs, clinics, and prayers together when they are sick. So in Africa, we combine the three sectors. That is why it is called pluralistic. And we are going to look at each of those sectors. In the popular sector, where most of the people, the sector that most people use, even cautiously or unconsciously, is the popular sector. It is the most common and accessible sector, and it represents the first line of defense. See, in Africa, usually there are those lines of defenses, and most of the people use them. If you feel that you have a fever, or you feel that you have a headache, there are those first immediate things you do, or what the community will tell you that the child has what? You go and get the other herbs, then you mix them, then you bathe the baby. Or even when you have flu, before you go to the hospital, you may even have tablets at home. When you have flu, you bring out the tablets you take. When you have headache, you get Panadol. So in the popular sector, it involves self-care. Many times people, they medicate themselves, whether they're using herbs or they are using this, or they are using tablets, or they use home remedies that you go and get warm hot water and do this, or advice from family members. This is the popular sector in most African countries. But there is also the biomedical sector, which is the former Western derived healthcare system. This one is based on scientific principles. In the popular sector, for example, in Uganda, the mothers can use common remedies. Whether it is malaria, they may get aloe vera, they crush it, they give to the patient. But in biomedical sector, which is usually the second line of defense, that if these ones have failed, the herbs have failed, you have tried Panadol, it has failed, let me go to hospital. Then you have gone to the biomedical sector. So it includes professional doctors, nurses, hospitals, modern treatments, and diagnostics. So this is the formal sector, and these are its main foundation assumptions. Number one is humanitarianism. The biomedical sector, they aim at alleviating pain, discomfort, and suffering. So this is the moral drive that underpins the ethical foundation of modern medicine. It aims at taking away pain, discomfort, and suffering, even in cases where there is no cure. Scientific rationality. Biomedical sector bases all its conclusions. They believe that disease is presumed to have specific causes which can be studied using scientific principles. That is biomedical sector. Everything should have a scientific basis. The rationality, the cause, or the perceived explanation for the illness should be scientific, not saying evil spirits did this. Number three is universality of disease. The biomedical model views diseases as a fixed biological reality, which is the same across cultures. It is not affected by beliefs, customs, or emotions. So if you believe that this ulcer is being caused by H. pylori, whatever the culture, whether you come from where, the biomedical sector has one explanation. So they don't take time to. Many times in biomedical sector, we don't involve what the beliefs of the people values. They use a causative agent and they believe it is universal. Number four, physiochemical data. Whatever conclusions they make, it is based on objective data, which even someone else can measure and get. They have to do lab tests, they look for vital signs, they do physical checkups, they take for your temperature. Since your temperature is high, they check your blood, you have a lot of, your platelets are very low, white blood cells are very low, then they make conclusions. So all their conclusions are on physiochemical data, not on beliefs which have been handed down from generations. So that is the biomedical sector. And the third sector in African medical system is the folk sector. And I believe in many, even in Asia, I believe Asia also has a pluralistic system. In the folk sector, which is usually the third line of defense, someone starts with self-medication, then they run to the hospital. When it fails, then they go to the shrine. So this is the indigenous non-biomedical health system. It is indigenous, meaning it varies from culture to culture, and it is rooted in traditional beliefs which are unique to certain cultural groups. It involves the traditional healers like the herbalists or bone setters, and also the spiritual healers and rituals. So that is the folk sector. These in certain countries or regions, there are some countries which have only one type of sector, the biomedical. Though it is hard that when someone is sick, they go to the doctor, they consult, they get medication. But in many countries, it is either two or three. But in Africa, three of them. So that is the African medical knowledge. Why is it important to understand the system in Africa? It is essential for effective public health and culturally competent care in Africa. When you understand this pluralism, it explains the real life health seeking behaviors, and it facilitates better patient engagement. If you have a patient with malaria in Uganda, you can combine a patient may combine the clinic prescribed medicine. You have given him Coartem, and they combine it with local herbal medicines. That is the reality in Africa. And this demonstrates a pluralistic approach. But it also helps you to know that sometimes or many times by the time people come to the hospital, they have already used various methods. And number three, understanding this African medical knowledge helps you to respect other healing paths because people value their cultures. Section 3, the World Health Strategy. Though still it is part of the African medical knowledge. That is where we talk of the Alma Ata Declaration. In this strategy, it emphasized primary health care and it suggested formal collaboration between the biomedical and traditional healers. So the aim of the World Health Organization was to improve healthcare access and effectiveness, especially in low-resource settings like African countries, by leveraging existing trusted health systems. So the World Health Organization actively engaged actively engaged in training, for example, birth attendants in Uganda. So that let us train the birth attendants on the safe delivery practices or on the referral pathways so that we collaborate with these traditional healers on HIV awareness to demonstrate a practical move towards integration. So the aim of the World Health Organization in 1978 is to integrate these systems, let them work together. So it is leveraging that, utilizing these systems, not living in blindness to assume they are not there. And they believed and explained that most of the problems in Africa, in our health system, it is because it is pluralistic. So that was the strategy. Their reasons for collaboration is that folk healers often represent the first and most accessible point of care in rural areas. Most of the folk healers are accessible, whether they are herbalists, whether they are spiritual healers or diviners. People know where they are and they easily access them. Number two, the folk healers are highly trusted even more than most in many societies, even more than the biomedical sector. So within their communities, and they are abundant where biomedical staff may be scarce. In many cultures, traditional healers are trained by that culture, and they are more. If you talk of traditional birth attendants, they are many. So in this, they say that if you collaborate, there will be the effectiveness in the medical system will be greater other than these sectors living in isolation. So that was the effect of the Alma Ata Declaration. It is the one that promotes primary health care, providing primary health care, that is dealing with illness at the community level even before they come, talking of immunization, vaccination, water and sanitation. But they also suggested collaboration of these three sectors in Africa. So after this declaration, there are four views on this collaboration. Four various views arose. There are those which are against and those which were for this collaboration. These perspectives, they influence how collaboration efforts are approached and received. We have antagonism, pragmatism, idealism, and skepticism. In antagonism, there is complete rejection of the other system. The other system, we are talking about the folk system. Antagonists, they completely reject that there should not be collaboration. This system is dangerous. This system of folk illness, it has a lot of problems. Let it be rejected. So those are the antagonists. The pragmatists, they talked about the strategic use of folk healers for specific public health goals. So pragmatists, there are some things they don't agree with the healers, but they say we can use them. So it is more of exploiting them. The idealism, which that's what the World Health Organization was suggesting, is they believed in genuine mutual learning and integration of both systems, that these systems can actually integrate and work together. Then the skeptics, their main concerns was about exploitation or loss of traditional integrity, and most skeptics were the traditional healers. So we are going to look at these views. Antagonism looked at the clash of systems, that after proposing this collaboration, this view sees traditional healing as unscientific, dangerous, or even fraudulent. So for them, they completely rejected the collaboration, and most antagonists were biomedical doctors, professionals, professors, so that this system will do more harm than good. It does more harm than good. Let it be rejected. So they advocated for strict biomedical dominance. Let biomedical sector remain dominant, and they refused to acknowledge or legitimize folk practices. Those are the antagonists. So you might have Ugandan health professionals who strongly oppose recognizing witch doctors or shrines in public health campaigns, that let them even not be mentioned. People should be discouraged from going to those shrines, to those witch doctors, traditional healers. And most antagonists, they cite risks like delaying diagnosis. For example, a patient with malaria, if we acknowledge the other system, someone who would have been given the antivirals or antibiotics is going to first go to a folk healer. They delay the illness, they become more problematic. So antagonists, they suggest strict biomedical dominance. But there are these two who suggested, yes, you can have some common ground. There can be common ground. The pragmatists and the idealists. The pragmatists, for them, they focused on practical benefits, because they view folk healers as valuable community health allies, useful for outreach, referrals, or health education, even if they don't fully endorse their methods. But the idealists, they believe in deeper synergy. For them, they envision that both systems can genuinely learn from each other, they share knowledge, they evolve into an integrated healing paradigm. Those were the idealists. They say that it can be perfect, it can be a perfect moral solution. The doctor is working hand in hand with a traditional healer, working hand in hand with a spiritual healer. But the pragmatists, they didn't like the whole idea, but said that we can utilize them. If you're having a public health campaign for HIV, people trust these people. Let us utilize them. The traditional birth attendants, let us train them and we use them as a workforce. So those were the pragmatists. In the pragmatists, if it is in Uganda, you can look at herbalists being trained to distribute and promote use of clean delivery kits for pregnant women. So they are leveraging their community access for public health goals. Since they are more accessible, people trust them, we can use them to enhance our community health strategies. Then in the idealists, they can talk of discussions in some medical schools about incorporating local botanical knowledge. Let it be taught to the doctors. Let also that traditional healers learn something from the what? They learn something from the biomedical sector. So they are not necessarily crushing any of them, but they can work together. If the traditional birth attendant has failed to deliver the baby, she can refer to a midwife in a biomedical sector. Those were the idealists. Then the skeptics, for them, they had concerns about the future. And most of their concerns were about the folk healer system. In this perspective, they expressed doubts and concerns about the true benefits of collaboration because they looked at a collaboration as an exploitation. The skeptics worry that formal integration might weaken traditional practices, that even if they may work together, a skeptic he sees that even if they may work together, it will weaken traditional practices. It might lead to exploitation of indigenous knowledge or misrepresent the holistic nature of folk healing for biomedical gain. And as I said, most skeptics were traditional healers. So there can be fears among some traditional healers that sharing their ancestral herbal knowledge with the pharmaceutical companies or researchers, it might lead it to being stolen, repackaged, or, or sold out without recognition or benefit sharing. That is the skeptic approach. So they view this collaboration as more of exploitative. It will weaken the traditional culture, it will weaken traditional systems. That is the skeptics. So that was about the African medical system. And I believe you can realize how culture is shaping health. Traditional beliefs, values, they shape people's health. Even if it's not in the biomedical sector, but in the traditional sector, people's beliefs and values, they shape what they believe illness is, the treatment they get. So it is necessary to apply anthropology in medicine. Section number 4, doctor-patient relationships. Doctor-patient relationships. Using all of these views we have looked at, using all of this information we have looked at in anthropology, how culture shapes health, how can the use of medical anthropology improve doctor-patient relationships? Why does a doctor-patient relationship matter? A strong, trusting doctor-patient relationship is foundational for effective medical care. It fosters open communication, it builds confidence, and it directly impacts diagnostic accuracy and adherence to treatment. If we use an example here in Guru, if you are at Lacho Hospital, a patient feeling comfortable enough to open to you, being honest, to honestly share their sensitive information, their symptoms, their personal history, when they are looking at you being friendly, empathetic, it often leads to more accurate diagnosis because they open up, they are trusting you, they are communicating well with you, and it leads to willingness to adhere to the treatment you are giving them. So doctor-patient relationships matter. And as we're talking about how to improve doctor-patient relationships, you need to understand illness. You need to understand how people view their problems. It is beyond diagnosing the disease. Doctors must strive to understand the patient's and their family's illness experiences. It includes their cultural explanations for sickness, their fears, and expectations. A culturally competent doctor When faced with if a child has a persistent fever, you may gently inquire about the local beliefs, these people believe is the problem, or their recent events, what does the family think caused it. That even if you know the cause, if you talk about it or you address it, fosters trust and adherence because you are putting into consideration their view. Therefore, to improve communication between the doctor and patient, you speak the language of the patient. Doctors should avoid complex medical jargon and use simple, clear language understood by the patient. Where possible, utilize local terms or working with trusted interpreters. You speak the patient's language. If you're explaining malaria treatment to a patient, you can use the widely used terms, your musuja, because if you use the terms they understand it, there is a way it bridges up the gap. And even when you're explaining the cause, you explain it in terms they understand. You also link the medication to the tangible benefits that they can recognize. How will they benefit from the treatment? We talked about the transactionalist perspective that many times patients view health those interactions in the hospital as a transaction. So explain to them the benefit rather than just clinical terms for parasites. Tell them names of germs. So you speak the language of the patient. You also need to practice self-awareness. You need to engage in self-reflection and acknowledge your own cultural backgrounds, your biases and assumptions. Understanding one's own lens helps avoid imposing biomedical values and promotes respect for diverse patient perspectives. You need to first view your own personal biases because if you're a doctor from Kampala, you are highly educated, all that. If you are taken to Karamoja, it is important to consciously reflect on your potential cultural differences with the patient when you're treating the patient because it will ensure you to provide respectful, non-judgmental care that considers the patient's unique worldview. So you also need to consider your own biases and you understand that there is diversity of cultures. Try to understand the people in their context. You treat illness and disease. Look at holistic healing. We talked about the biopsychosocial approach, which is Angel's model. Effective healing goes beyond just treating the physical disease. You need to address the patient's subjective illness experience. How do they feel? What do they think? You include their emotional, their social, their cultural, and spiritual needs. A holistic approach recognizes the interconnectedness of these approaches. Maybe if you are treating a patient with HIV, if you have after giving them the treatment, you might encourage them to involve their spiritual leader, or you involve trained counselors in the comprehensive care plan for the patients. So in this case, you are acknowledging the patient's spiritual distress because many times it is not the physical alone, but the mind, body, and the spirit they are involved in determining their health. So don't just focus on the medicine. True healing is more than just medicine. It is caring for the whole person. Respect diversity. There are many paths to healing. For example, in African medical system, we have seen the biomedical, the popular, the traditional healing. So you need to acknowledge that Western biomedical approaches are not the sole valid path to health and healing. Recognize and respect the efficacy and cultural significance of other healing modalities within the people's context. You need to recognize, not to dismiss their cultural their cultural healing methods. For example, you may look at people doing traditional steam baths used in some villages for conditions like colds, maybe if they have body aches, Even if you are providing them with biomedical treatment, if you acknowledge their healing methods, their better treatment results. Assess the context. We have talked of the case of Karamoja. Look beyond the clinic. Effective doctors must consider both the internal factors, that is what the patient believes, their culture and their emotions, but also the external factors like environment, socioeconomic status, can be poverty or the community. All these factors affect the patient's health, not only the bacteria you are testing for. So if you ignore this broader context, it can lead to ineffective treatment or to poor adherence. If you are treating frequent diarrheal diseases, look beyond prescribing medication. Consider the patient's living conditions. Where do they live? You're treating a patient from Katanga where maybe there is poor sanitation, lack of clean water. They are crowded. You also address these issues. Because if the case is recurring, meaning the problem is beyond the clinic. An example case I can use is the case of pneumonia. A child diagnosed with pneumonia may not recover fully if you as a doctor you only prescribe antibiotics. That is if the patients have their explanations. So if you're in a culture where they believe the impel, the bad wind or evil wind is causing it, if you only look at your perspective and ignore the family's belief, many times the patient will not fully recover. So effective care, you combine antibiotics with clear culturally sensitive education. Educate these people. You explain to them the pathophysiology, how you explain that it is being caused by this. Actually, it is not evil wind. Because if you only give them medication, they might even take it once and dump it. So even the adherence is poor. So in this case, the pneumonia case in a certain society where they believe it is evil wind, just giving them antibiotics will not help them to recover. So patients may not recover if their understanding of the cause differs from the doctor's and if it is not addressed. So and also still if you don't know it, you cannot address it. That is how anthropology becomes important. In holistic care, integrates medical treatment with a cultural understanding. The summary of doctor-patient relationships. The tips for success. You say that you listen actively, listen to the patients, give them time to explain their problem. You speak simply, avoid jargon, use clear, understandable language and local terms where appropriate. Number three, respect people's culture. Acknowledge diversity of beliefs. Number four, treat holistically. Address both physical disease, patients' emotional, social, and cultural illnesses. The third last, section 5, health risk behaviors. And we are going to use them to relate to three disease conditions: HIV, Ebola, and cholera. And in these health risk behaviors, you understand that culture in every way affects people's lives because it is in these cultures where we find these health risk behaviors. A health risk behavior is a specific action or a choice that significantly increases an individual's or community's chances of developing disease, injury, or premature death. In brief, any action, any choice people do that increase their likelihood of developing disease or getting injured or premature death is what we call health risk behaviors. These behaviors are often preventable and are critical targets for public health interventions. Most of these risk behaviors can be changed if people are informed, but because some of them they are in their society, the family they have grown up in, maybe it is religion, it is bringing up these behaviors that are becoming a problem to their health. If you are consuming food and beverages, there are many areas in Kampala where you find high cases of typhoid, high cases of high cases of diarrhea, but it is because it can be due to a simple way of life, a behavior like buying food from unsanitary street vendors. When someone has a tendency or a habit of buying food everywhere or even in areas which are not hygienic, then it becomes a risk behavior. Understanding risk behaviors is powerful for prevention, especially in public health. If you understand risk behavior, it is important to understand because a vast majority of illnesses, especially in Africa, particularly in developing countries, are preventable through behavior change and improved living conditions. So, investing in prevention is far more cost effective and impactful than treating established diseases. During the Ebola outbreaks here in Uganda, you found that consistency and proper hand washing with soap and clean water, it was the critical prevention measure. So just failure of people to adopt just a simple behavior of washing hands with soap, it significantly increased the risk of transmission. So even simple behaviors like that can put people at risks. Therefore, if we study societies, if you are a medical sociologist, you go to one area where certain maybe diseases are prevalent, then you study their behaviors and how they put them at risk. Then it will inform public health policymakers so that they prevent disease. There are very many examples of health risk behaviors. They include harmful traditional practices, unsafe sexual encounters, environmental health negligence, and as I said, health risk behaviors can be at an individual level by someone's choice. Maybe if you talk of smoking, drunkenness, that is someone's choice, but there are also risk behaviors which at community level or in a culture. If you talk of female genital mutilation among the Sabini, notably in Kapchora, it is their culture and it is a severe health risk behavior with profound physical consequences. So health risk behaviors can be in people's cultures. HIV or AIDS. HIV is primarily transmitted through exchange of specific bodily fluids. We know of the semen, the blood, predominantly through unprotected sexual contact. So understanding these transmission routes is foundational for effective prevention strategies. Now, mainly in Uganda, are using the ABC campaign, abstain, be faithful, use condoms. But to make these interventions, it was through the work of sociologists and anthropologists. So knowing how HIV spreads, you understand the health risk behaviors for HIV. For example, there are specific risk behaviors like unprotected sexual intercourse, whether it is vaginal, anal, or oral. And many times it is emphasized by the cultures. It can be cultural taboos towards family planning. Or if you talk of certain practices, maybe you talk of having group sex in certain cultures, people have group sex, they have multiple partners, that is a health risk behavior. Sharing contaminated needles or syringes. If you talk of a social group of drug users or drug addicts, many times they share syringes and needles, and it can be a health risk behavior. In talk of transfusion of unscreened blood or blood products, in Uganda there is that practice of exchanging blood. It's called okutomukago. I'm not sure. But just a practice like that, it's a traditional practice, but it's a health risk behavior because people can exchange. In this exchange of blood, they may get HIV and other infections. You talk of mother to child transmission during pregnancy, breastfeeding, or childbirth. So many of these, and during the times when HIV cases were high, the late 20th century, many anthropologists made a study about the health risk behaviors for HIV because currently we have no treatment. Meaning, if we address these health risk behaviors, whether it is unprotected sex, whether it is sharing needles, so you assess the society, you look at their risk behaviors, then you inform public health practice. But why do people take risks? Many times people know that they are risks. Many people are now educated. You're smoking, you're taking alcohol, but you are educated and you know it is a health risk. And you understand that there are complex and multifaceted reasons why people involve in risks even when they know. Number one is poverty. Someone cannot access, maybe they feel they cannot manage mosquito nets, they cannot boil water, maybe because they have no electricity, then they have to take the unboiled water. They are taking risks because of poverty. Many times it is not solution. They can be social pressures, like we talked of that thing of exchanging needles among the drug addicts. But you talk of also social pressures from the society. If it is a culture, you talk of FGM is a culture, meaning you get that social pressure from the community, and the people continue to engage in them even when they are risky. Limited access to resources and ingrained cultural practices. Some cultural practices are so ingrained in people's culture that it is hard for them to do without. But in tackling these health risk behaviors, there is a social cognitive theory that emphasizes that behavior change is influenced by personal factors, environmental factors, and behavioral factors. And if you look at these factors, most of them can be changed. Personal factors are mainly due to people's beliefs and their self-efficacy. Environmental factors can be changed, behavior factors can be changed. Self-efficacy is a belief in one's ability to perform a behavior. So we believe that if people are educated and they are told the problem of these health risk behaviors, they have ability to choose what to do. That is what we call self-efficacy. So this promotes that when people are educated, people are more likely to adopt healthier behaviors because of self-efficacy. Section 5, Ebola and cholera. It is just a continuation. We looked at health risk behaviors, which were for the case of HIV, but in the case of Ebola, specific cultural practices like traditional burial rituals were significant drivers of Ebola virus during outbreaks. So these rituals often involve close physical contact with the deceased who remain highly infectious. You know that for example in the 2012 Ebola outbreak in Burundi video, it was reported there was a customary practice of women washing and preparing the bodies of deceased relatives. So you find that it is the rituals that are bringing a health risk behavior. And it included also those who died from Ebola. They also have to do this cultural practice, and it led to rapid spread of the virus. But still in cholera outbreaks are directly linked to poor hygiene practices and inadequate sanitation, especially in densely populated areas. In Kampala, there are recurrent cholera outbreaks. They are recurrent from time to time. Like if you in Bwai, say in Chisenyi, in those slums, primarily due to contaminated water sources, the shared taps, the wells near the open drainages. So the living conditions, the society that people live in, it impacts their life directly. Using those four examples you have talked of, you can talk of improper waste disposal. It can be someone's habit, which is putting them at risk of disease. The solutions to health risk behaviors. Effective strategies to mitigate these health risk behaviors involve a multi-pronged approach. where we are combining educating the people, because you have realized many times people do it unknowingly. They don't know their health risk behaviors. Infrastructure improvement. If you talk of political economic reasons, people are living in slums, the water is contaminated, or the housing is poor. Then that needs infrastructure improvement, not just educating the people, and also promoting culturally appropriate safe practices. They need to be addressed, the cultural practices that put them at risk, or suggest culturally appropriate safer practices. The second last section is about marriage and family. When you are studying societies, actually I think the fundamental unit of a society is a family. Most of the things people do, they are groomed in the family. Marriage and family, they are an integral part of the community, of the society. So there is no way you can study anthropology or you study sociology without ignoring the fact of marriage and family. Why do we study marriage and family in sociology and anthropology? Marriage and family are universal social institutions, and they are crucial for society organization and continuity. They define the roles people do, they organize labor, they ensure child care. This is all done in families, and they regulate property transfer and inheritance across generations. If you look at the customary marriages, like in Soga region, there is that practice of Okwerula, or let us say paying bride price, often using animals or money. And it formally establishes the union between these two people. It delineates the responsibilities they have to do. It organizes the family assets. So, and many times the family, if it is for the children, it is their first school, which provides a lasting foundation. So, understanding how society influences people's behavior and how it will affect their health, their marriage is the central unit. If you look at some of the functions of marriage in our community, they provide stability, they ensure social reproduction, they transmit culture because it is through the marriage and family where the parents will transfer the culture to the child. They manage resources. Marriage and family regulate sexual activity and reproduction because it provides a stable context for raising children. In regulation of sexual activity, we talk of the taboos, no incest, no this. There is economic cooperation because in a family there is sharing of resources and labor. There is social cohesion and identity. Families provide belonging and support, and this is very good for people's mental health. Families ensure property transfer and inheritance, and this reduces conflicts among families. They define the lineage and the succession. The types of families, the nuclear family and extended family are known, but there are also types of households. If you talk of the single parent household, where one parent is raising the children. We talk of polygamous households, which are many in Uganda. One individual has multiple spouses, whether one man with many wives or one woman with many husbands. We also take of same-sex households, individuals of the same sex raising children. So all these are an integral part of the society. The nuclear family is increasingly more common in many urban centers in Uganda. But the polygyny, that is many wives, one man, is also common. It remains practiced and generally legally recognized in Uganda. So these family types, they vary, but their core purpose of nurturing remains the same. In all families, they nurture the children, they nurture their behavior, they determine their roles, they determine what they do. The marriage rules. If we first talk of the incest taboo, almost in all societies, they forbid incest. There is no sexual, they don't allow sexual relations between closely related individuals. And the purpose of these taboos is primarily to prevent social conflict. Because if people from the same family having two brothers fighting for their sister, then the family will disintegrate. So it prevents social conflict, it maintains family roles, and promotes wider social alliances as people interact with they marry with other families. So they are having wider alliances. You talk among the Baganda, in the Maganda, you cannot even marry in your own clan, even if it is not a family. So it promotes wider alliances. But there are other advantages of marriage rules. How are they important for the society? How are they important for their health? The marriage rules, they reduce internal family conflict, like we have talked about, the incest taboos. They prevent genetic inbreeding, which reduces risk of inherited genetic disorders. If you're having a family with sickle cell or with a lineage of hemophilia, if they intermarry with varied people, it prevents those risks of genetic inbreeding. It avoids family disruption by maintaining clear roles, minimizing sexual competition. It forms wider alliances. Number of spouses, that is when we talk of polygamy and monogamy. If you're in a family with one spouse at a time, which is the most common globally, that is monogamy. Then polygamy, having more than one spouse. Either it is polygyny, where there are many wives, one husband, and polyandry, one wife, multiple husbands, and that is very rare. Another concept to know about family, that the family patterns go on changing. Family structures and functions are not static, they evolve significantly. And this is because of urbanization. If you had a rural area and becomes urbanized, even the family structures change. The work that people do. In the last section, we are going to be looking at people and work. It affects their families, the organization of the society. If people's economic conditions change, even their family patterns they change, and also the shift in societal values. This leads to smaller families, delayed marriages, and new household compositions. For example, urbanization in Kampala contributed to a notable rise in single-parent households. Because now we're having many families with single-parent households, and can also be contributed due to the new policies. If now divorce is legally recognized, then the family patterns will also go on changing. The nature of work people do, you find that the woman is staying with the children alone, the husband went to another place, is working in another area, leading to prevalence of many single parent households. So family patterns go on changing due to those reasons. We talked about benefit of marriage as building bridges. It links families and kin groups, fostering broader social cooperation, and it reinforces community unity. This social cohesion brought by families, it creates complex networks for relationships that provide support and stability. We talked of that the Buganda Kwanjula ceremony. That when these two people get married, it is not just these two people uniting, but actually the two families are uniting and provides social support. It provides even economic support. Marriage and economic roles, there are shared responsibilities when people are grouped into families. Marriage serves as an economic unit, organizing and allocating labor and resources between the spouses based on gender roles, skills, and traditions. Gender and gender roles is just a subset of sociology because it is the society that determines these gender roles. This division of labor ensures survival and prosperity of the households. In many Ugandan households, the gender roles, like what a man has to do. Maybe a man will be engaged in more hard work or in heavy agricultural tasks, while the women will be in home gardening, in childcare. All these are provided for by the families and marriage setting. So in this case, marriage and family is a basic core concept for the health and well-being of the people. We talked about managing conflict. When people get married, you know that this one belongs to this one. It reduces the sexual conflicts. It controls sexual competition and establishes a clear lineage. It brings order and predictability to social relations. If they are polygamous marriages, many times they expect that they are respected elders who have to intervene when there are conflicts. So without this marriage setup, many societies will break down, have high cases of mental disorders, high cases of poor mental health, all stemming. So that is the beauty that we get from marriage and family. And lastly, marriage and cultural change. We say that marriage evolves. Marriage is not static. It undergoes significant transformation, influenced by processes like modernization, urbanization, globalization. So this often shifts the emphasis from arranged unions based on family alliances to choices driven by romantic love. Long ago, many times marriage was an arranged union. Families sit big. Actually, sometimes marriages were just organized for their children, but now marriages have evolved. It depends on who you love, more of romantic love. The legalization of civil marriages and church marriages, that nowadays it is more prevalent than the traditional marriages. So marriage and culture goes on evolving. And our last part is about people and work. How does the work that people do affect their how does work that someone does shapes their lives? And in the case of anthropology and medicine, how does it affect their health? You realize that there are many jobs that people do that are actually bring their own health risks. Someone working in a landmine and someone working in an office, they will have different health issues. And this is all brought about by people and the work they do. So on and on again, you see that society shapes people's health. Why do we need to study people's work patterns? If we understand how people work, it provides deep insight into how societies organize themselves to survive, to sustain their populations, and to adapt to their natural environment. And this concept is employed a lot in the ecological perspective, how people's environment shapes their health. The work patterns are fundamental to a society's social structure, to the economy, and way of life. If you contrast between the Karamajongs who are doing pastoralism as their work or their way of life, and you contrast with maybe the Banyankole who are, or you contrast with the emerging industrial jobs, people working in offices, people working in factories, the people in nomadic pastoralism and this industrialized age, they have different problems and it shapes their lives differently. If we talk of hunting and gathering, and this is the oldest and simplest, where people obtain food by hunting wild animals, by fishing and gathering wild plants, fruits, and nuts. If you have heard of the Abattoir community, the Pygmies, particularly in certain areas, or if you go to the Congolese, you may find still there are people who are still practicing this hunting and gathering. So for them, they rely on the forest's resources for food, for medicine, for shelter. So their way of work is influencing their lives. Remember, in sociology, we see how society and human behavior shapes people's lives. So people's work shapes their lives. and it will also shape their health life. Their well-being is different because of their way of work. We have talked about pastoralisms, people living with livestock. Pastoralism involves the domestication and rearing of animals for food, milk trade, and other products. The societies practice this in areas which are usually unsuitable for intensive agriculture, that like if you talk of Karamoja, whether nomadic or semi-nomadic movements. So in pastoralisms like the Karamojang people, they are a classic example. They rear cattle as cattle is central to their economy, their social status and cultural identity. The number of cattle that someone has determines their wealth, their social status. So it is an integral part of their way of life, and it forms the basis of their trade and their wealth. For them, where there is a cow, there is a traditional pastoralist life. It also shapes their lives in that way. Talking of horticulture, which is just simple cultivation, small scale, non-intensive farming, typically using simple hand tools like hoes, and rely on rain for water. Many societies practice horticulture. It involves slash and burn, where plots are cleared, they cultivate for a few seasons, then they leave the plot to regenerate. Many subsistence farmers in many districts practice horticulture. They may grow some maize, some beans, some cassava, using basic tools, hoes, and that is their way of life. Agriculture, it is intensive farming, is more than horticulture. Here, people involved in intensive cultivation of land using more advanced technologies. They may use plows, they may use irrigation systems, fertilizers, and often use permanent fields. It supports larger populations and can produce surplus for trade and specialization. Agriculture is more of large-scale farming, usually for commercial reasons, where I talk of sugarcane plantations, like in Ginger, the Kachira Sugar Works. So there is intensive agriculture, and it will also shape the people in that region. You find that it shapes their lives differently, and also their health risk behaviors are different. And lastly, the industrialization, the machine age. Industrialization, societal shift from agrarian economies to manufacturing. For which it involves the widespread use of machines, factories, and new technologies to produce goods on a mass scale. It leads to urbanization and new forms of work. And this is one of the reasons that has led to modification of many societies, industrialization and factories. And it has also brought in different risk behaviors. This transformation in people's work, actually it has transformed people's lives. You realize that even the trend of diseases has changed because people and work has changed. So what people do shapes their lives and affects their health. Talking long ago of the infectious diseases, now we are talking of non-communicable diseases. It is due to change in people and the work they do. The major shifts in work patterns impact social structures. This change in work patterns, it leads even to changes in family roles. We talked about that in marriage and family, that people's work, the change in the society led to a change in family patterns. There is massive role to urban migration. You find people from many regions in Uganda migrating to Kampala because of work. There are new social classes due to work, the kind of work patterns, and there is shifts in economic power. So people and work inevitably influences people's lives. So you need to address any region you are dealing with, addressing the kind of work they do and the risk behaviors it brings up is important in treating them. So we can now make a conclusion from where we began from, conclusion and discussion. We started with culture and health, and we saw that culture profoundly shapes how individuals and communities understand how they prevent and respond to illness. We have seen that culture defines beliefs about disease causation, people's preferred treatments, and their health seeking behaviors. We talked of believing witchcraft as a cause of severe convulsions instead of talking of cerebral malaria. And we saw that understanding these two perspectives, understanding the people's perspective, is important in their treatment. We have looked at doctor patient relationships. A strong doctor patient relationship has to be built on active listening, mutual respect, cultural understanding, and this is crucial for the successful treatment outcomes. We have seen that effective communication bridges gaps in understanding. So, a doctor making the effort to explain a diagnosis and treatment plan to a patient in their local language, he creates trust, it ensures understanding, and it significantly improves the adherence of the patients to the treatment. And all this comes in using the knowledge of anthropology. Number four, we talked about health risk behaviors. We have seen that a significant majority of illnesses are caused by preventable health risk behaviors, which people decide on their own. Some are in their cultures, some are in their rituals. So, targeted health education, community awareness is critical for prevention. We talked of self efficacy, that most people, when they are educated, they can decide their behavior. Number five, the African medical system, so that it is pluralistic. Healthcare in Africa is characterized by a pluralistic system where individuals often navigate and combine various sectors. The popular sector, which is home care, self-medication, or getting advice from people. The biomedical sector, which is the formal clinics and hospitals. The folk sector, which involves traditional healers and spiritual healers. So this African medical system reflects diverse beliefs and access. We looked at a common example of that villagers will try to first use local herbal remedies before they seek care at a clinic. And sometimes they may use both concurrently. They both use both their home remedies with the biomedical treatment. So understanding that enables us to better understand the patients. Number six, you have looked at marriage and family as the society's core. Marriage and family are fundamental institutions because they structure society by defining roles, organizing labor, facilitating inheritance, and promoting social harmony. And we have seen that family and marriage are dynamic and they adapt to changing times. We talked about the interclan marriages in Uganda, that they promote wider alliances, they provide social support, which is good for people's mental health. And lastly, we have looked at work and evolving livelihoods, seeing that work patterns are central to how societies function and adapt. And me, in ecological perspective, looking at how people's work affects them is crucial because work patterns, they shape the society. Shifts in work profoundly impact social structures, family roles, and economic landscapes. So in conclusion, we need to integrate the sociological and anthropological understanding into your daily medical practice to improve service providence. And this means recognizing, respecting, and working with cultural realities to provide more effective and patient centered care. Thank you for watching and share. You can subscribe.